welcome to today's ESC Working Group on Aorta and Peripheral Vascular Disease webinar on the first part about lower extremity artery disease. Why and how should I diagnose LEAD or lead? I'm Professor Arno Schmidt-Truxes from University of Basel, and I have the pleasure to being joined by Professor Rupert Bauersachs from the Department of Vascular Medicine of the Hospital Darmstadt, and Professor Oliver Schlager from the Division of Angiology at the Medical University of Vienna. The aim of this webinar is to give you a better understanding of the prognostic burden of peripheral artery disease and to learn the diagnostic tools and algorithms needed. We will provide you with background information and explain it using clinical case presentations. This session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of multiple choice questions that will be submitted during the presentations. This program is supported by Bayer in the form of an educational grant. The scientific program has not been influenced in any kind by the sponsor. I will now hand over to Professor Bauersachs to his first presentation.
Thank you very much, Arno. My topic now is epidemiology and the prognostic burden of lower extremity artery disease. Why is lead still underestimated? These are my disclosures, and I would say that lead is not only underestimated, it's also, as we may see then, it's underdiagnosed. And I want to illustrate that with the first case. We start right with that case. It's a 60-year-old male patient. He's a salesperson, and he comes into a private practice, cardiology practice, for regular follow-up because of his CAD. He had PCI after myocardial infarction 8 years ago. He currently has no complaints. He has a family history of myocardial infarction. He has not completely quit smoking. He's 78 kilograms, 181 centimeters, so he's not overweight. His medication include antihypertensive medication, aspirin, a statin, ezetimibe, and his blood pressure and lipids are in target. So that is good. And on the way out, when he says goodbye, he turns around and said, I have a question here. Doctor, what should I do with the aspirin during the planned injections my orthopedic surgeon wants to give me into the hip because of my hip pain when I walk? Oliver, what do you think when you hear something like that? Complaints when walking?
Robert, I think when I view the risk factors of this patient and his medical history so far, and especially the symptoms he's reporting, I would think of checking his peripheral arteries and to check for lower extremity arterial disease.
Yeah. Absolutely. And I think it's easy because you would really have to specify his complaints. He says, after asking, right-sided buttock pain after 100 meters walking distance, and it stops when he is at rest. And then I think it's also important to ask him about erectile dysfunction, and he then says, yes, I have erectile dysfunction. And as you just pointed out, this is a patient where you have to look for PAD or lower extremity artery disease. He has a weak pulse in the right groin, and this patient needs a diagnostic workup for lead, and we will hear more about that later on. I would like to start with reviewing the epidemiology of lead, looking at risk factors at the different clinical stages, briefly address revascularization in lead patients and the challenge of acute limb ischemia. Again, for the definition, we have to see that we have several diseases under the umbrella of peripheral artery diseases, and that include carotid artery disease, that includes upper extremity arterial disease, but also includes mesenteric artery disease, renal artery disease, and now, of course, the topic that we have today, lower extremity artery disease, lead. And these are data from the Global Burden of Disease study 2016, and you can see that the prevalence of lower extremity artery disease worldwide is very high. It's 120 million, and recent data show us it's even over 200 million. So it's a very frequent problem. And we have many epidemiologic studies that show us, including large studies here, that the prevalence is strongly age dependent. So it is much more common in the elderly population with a prevalence of 20 or more. And it's striking if we look at the change from 2000 to 2010, you can see that especially in that age range, there is a strong increase in the prevalence of lead. Now let's have a look at the risk factors. And smoking is a very strong risk factor for patients with lead. And if you look at the dose measured in pack years, you can see that there's a strong dependence on the pack years that the patients report and the incidence of lower extremity artery disease. And this is not a linear scale. You see it's eightfold increased in those patients that have 60 pack years or more.
Robert, just a question, short question. We know smoking is a risk factor, but we know the prevalence of smoking is reducing over time.
True.
And there's still an increase with age. How do you explain that?
Yeah, that's a very good question. And what we see, and that was also shown in the slides that I showed before, that we have a change in the population. We have an increase in the elderly population now in Europe and worldwide. And these patients have comorbid conditions. They have more diabetes, they have more chronic kidney disease, and therefore the risk for developing lead and generalized atherosclerosis is much higher.
Okay.
On the other hand, if you would take away smoking, you can see that the prevalence of lead would be more than 40% lower. So it's a strong risk factor still, but we have a change in the risk population today. Other risk factors, of course, are hypertension, and this is especially relevant because it's so common, and you can see that the risk for lead is increased more than twofold. Cholesterol, of course, is also a risk factor in lead patients. Diabetes is a very strong risk factor for lead with an increase of the odds ratio of 2 to 4. But particularly diabetes goes together with an increased risk for amputation. Diabetes often affects the distal arteries in the lead patients. It's combined with neuropathy with a high risk for infections or development of gangrene. Let's look at the different stages of lead patients. We have two classifications. In Europe, we mostly use the Fontaine stages. In the Americas, it's more a Rutherford category. But anyway, we distinguish between asymptomatic patients and then the population with intermittent claudication. Those patients develop pain while they are walking. And we differentiate those patients with non-disabling intermittent claudication. Usually this is when the patient can walk more than 200 meters, and disabling intermittent claudication. If the peripheral perfusion decreases more, the patient will develop ischemic rest pain, usually during the night. That's when the perfusion goes down, the patient puts his leg out of the bed. That's typical for the ischemic rest pain. And then, of course, we have minor or major tissue loss in those patients with very severe stages of lead.
Just a moment. What do you use more, the Fontaine stage or the Rutherford categories? What do you use usually in your practice?
In Germany and in many parts of Europe, we use the Fontaine stage. But as I pointed out, in several countries, the Rutherford categories are used. But as I showed, it's really comparable. And again, the differentiation is between the claudication patients with severe claudications, where you think of doing revascularization, and I come back to that later on. And the severe stages are either 5-6 Rutherford or Fontaine stage 4. This patient, as you can see, also has had an ulceration, lost his toe, and this patient has diabetes and he has palpable pulses. So he does not have lead, but you can see this is still a dangerous situation. And the most severe situation is when you have a combination of lead together with a diabetic neuropathy, as you can see here. Those patients have a poor prognosis, both for the limb and for the life. Now, what's the frequency? What's the proportion of patients with the different stages of lead that we see in our daily practice? It really depends on your environment. If you are a cardiologist in private practice, I would assume that the proportion of asymptomatic lead patients is very high. It's higher than here in the registry where the data were obtained from vascular practices mostly. If you work there, then you see a lot of patients in the registry who have intermittent claudication. But you also have a quite large proportion of patients that require revascularization and even have to undergo amputation. So the spectrum really depends on where you are working. In the vascular centers, you have the more severe stages, and in a cardiology practice, you have a lot of asymptomatic patients, and we point out later on why it's important to address those patients. And I would point out again that lead is currently underdiagnosed. Many patients with lead are asymptomatic, but we know that even the asymptomatic patients have a very high risk for cardiovascular events. And as you can see here, and we will hear that later on from Oliver, the diagnosis of lead is very simple, it's very reliable, and you can use these old-fashioned instruments. Now, what's the outcome? What's the fate of patients with lead? Asymptomatic patients may progress to intermittent claudication, and those may progress to worsening or critical limb ischemia. If we look over a 5 years time span, you see that about 70 to 80% of the patients remain stable. About 10 to 20% have a further reduced walking distance, and about 5 to 10% develop critical limb ischemia, and 1 to 3% have to undergo amputation. That's the outcome concerning the limb. Let's have a look at the general prognosis, the systemic prognosis, and that is very severe. All-cause mortality in those patients is high. It's 10 to 15%, and the majority, 3/4 of the mortality, is cardiovascular mortality. And in addition, there's 20% non-fatal myocardial infarction and stroke in those patients with lead. Why is that? Because we have polyvascular disease. We have an overlap between those patients that present with lead, and more than 60% of the patients with lead also have either coronary artery disease or cerebrovascular disease. And therefore, the risk for stroke is increased by 2 to 3 in the lead patients. And at the same time, of course, those patients have a 4-fold increase of suffering fatal myocardial infarction. So polyvascular disease is really the challenge that we have, and therefore our treatment strategy is really both. We have to do something about the symptoms of the patients, exercise training, pharmacological interventions, endovascular or surgical revascularization. But it's very important to do all that we can for cardiovascular risk reduction. Lipid lowering, antihypertensive drugs, diabetes therapies, smoking cessation, very difficult in some of the lead patients, antithrombotic drugs, aspirin, clopidogrel, and other options that we have here.
Rupert, may I interrupt you very shortly? I think you pointed out one very important point, that we have to be careful in giving the indication for intervention for endovascular treatment or surgical treatment. Despite we have seen a lot of progress in different treatment modalities for revascularization over the last years, we still have to decide whether to intervene or not to intervene, since we often still see recurrence rates in patients after peripheral revascularization?
This is a very important topic, and this really addresses the revascularization. If a patient has, of course, progressed lead disease with gangrene or rest pain, these patients have to or should undergo revascularization if possible. But if a patient has intermittent claudication, if it's not severe, we really have to think whether this patient really has to undergo revascularization. And later on, I will show you some data where you can see that the risk of suffering acute limb ischemia after revascularization is high. And as you just mentioned, the risk for progression may be increased after the revascularization, and therefore we have to consider carefully which patient should undergo revascularization and which patient where we have to do the best that we can, of course, to do the conservative treatment with cardiovascular risk reduction. And unfortunately, we did not see until recently a lot of improvement in the lead patients. If you look at these several studies over the last decades, there was not a big improvement in lead mortality. And this is sometimes due, of course, to the uncertain benefits that we have for aspirin, for example, poor implementation of secondary prevention. Lead patients receive usually a lower standard of secondary prevention compared to CAD patients. And as we pointed out and discussed earlier, we have less smokers. We have a more aging population with multiple comorbidities. We have more women and more underlying diabetes and metabolic syndrome.
Do you have any explanation for the less aggressive prevention or treatment?
That's a very good question. We have many studies also from the REACH registry. We see that the risk factor management, lipid management, hypertensive management is less good and according to standard in the lead patients compared to CAD patients. That has several reasons. It has to do with social status, for example, with education. It's also probably a psychological effect that a myocardial infarction has a strong effect than limb necrosis, for example. So there are many, many different aspects, and we have to know that, we have to accept it, and we have to really intervene and treat those patients with lead according to the guidelines and try to keep that standard high. And as I pointed out, we have polyvascular disease. Again, these are very interesting data where you look at the number of affected vascular beds. For example, if a patient has lead only, the 1-year risk for these kind of complications is 12.6%. If that patient has 2 vascular beds, lead and coronary artery disease, the risk is above 20%. If the patient has 3 vascular beds, for example, lead, coronary artery disease, carotid disease, 26% per year for these complications. And that's why I think it's so important that we look for polyvascular disease and do everything that we can for secondary prevention. And that was the question you raised before. This is the group of patients where you consider revascularization. Patients with rest pain would need revascularization, of course, if there's tissue loss. But patients with claudication, we really have to weigh the balance the risk of further decrease and further complications in those patients. And we know that from several studies, from the TRA2P study, for example, we know that the risk for suffering an acute limb ischemia is greatly increased in those patients that had a previous revascularization. It's even higher than patients compared with current smoking. Similar data from the Euclid trial, where you can see that the risk for myocardial infarction or the risk for acute limb ischemia is increased once you perform a revascularization compared to the patients that only came into the study because of a low ABI. And we have very similar data from the COMPASS studies telling us what happens if a patient suffers a major adverse limb event, if this patient, for example, has acute limb ischemia. If that happens, the risk for death goes up 6-fold, the risk for amputation goes up very high, and the combination of MACE and total amputation is 10-fold increase in the aspirin patients. It's interesting to see that those patients that also had rivaroxaban and aspirin did not show that increase in that high complication rate after MALE. So in conclusion, we've seen that lead is very common. It is an age-dependent disease and is increasing in prevalence. Lead comprises different stages from asymptomatic patients to intermittent claudication, acute limb ischemia, and gangrene. There's a high cardiovascular risk even in the patients that are asymptomatic. There's a high risk of major adverse limb events with poor outcome, as we've just seen. And there's a need for effective treatment to prevent both MACE and male. The challenge that we have is the high-risk groups, and that is the combination, for example, lead plus diabetes, lead plus renal insufficiency, polyvascular patients, combination with coronary artery disease and or carotid disease. So these are very high-risk patients. And in summary, lead is underdiagnosed, lead is often missed in everyday practice, and the diagnosis of lead would be very simple, inexpensive, and reliable. And we hear that in a minute, but before that, we have some multiple choice questions for you. Okay, so let's go and look which is the correct answer of those 5 choices. Lead occurs mostly in middle-aged men. Patients with polyvascular disease have a high cardiovascular risk. Patients with asymptomatic lead have a low cardiovascular risk. Patients with asymptomatic lead require rapid revascularization. Clinical diagnosis of lead is difficult and very unreliable. So these are your options. Please vote.
Okay, yeah.
Okay.
Yeah. I think it is an interesting question because it somehow highlights also, what you have mentioned before, how the risk factors also changed over time. Do you think this question would have been the same, let's say, 10 years ago or 15 years ago?
No, the right answers would have been probably different. Yes, we'll see that in a minute.
We have the results.
Oh, we have the results already? Okay.
Yes.
Okay.
So it's clear patients with polyvascular disease have a high cardiovascular risk.
Yeah.
It's really 92%.
But it's what Oliver said. I think 10 years ago, I mean, it was usually middle-aged men, smokers. So that has changed. Yeah. And we have to think of those old ladies, and they often have very subtle symptoms. They don't report, I have claudication, but they have subtle disease, they have insecure gait, and that could be lead.
Yeah. So it's not only to ask for smoking, but it's really to find the diagnosis.
Yes.
Yeah. Okay. Yeah. Good. So many thanks, Rupert. I will now hand over to you, Oliver, to your presentation. It's your.
Yes, thank you very much, Arno, Rupert. My presentation is supposed to address the question whom to screen for lower extremity arterial disease, and maybe also very important, how to screen for lower extremity arterial disease. These are my disclosures. For the next 15 to 20 minutes, I prepared 2 clinical cases in order to illustrate guideline recommendations for the first steps in the diagnostic workup of patients in suspicion of lower extremity arterial disease. And this is our first case. It is a case of a 62-year-old male patient who came to our outpatients clinic, and he reported calf pain on walking in his right leg. He said the pain-free walking distance was 50 meters. The onset of symptoms was approximately 3 to 4 months ago. The patient did not report rest pain, nor did he exert any ulceration on his legs. However, the risk factors of this patient, you can see here, the medical history of this patient comprised a history of coronary artery disease with a history of a stent PCI of his right coronary artery in 2017 after an acute myocardial infarction. And his risk factors also included arterial hypertension besides the history of smoking. And I think it's very interesting because this case is a little bit similar to the case Rupert presented before, because what was surprising for us was that if you view the risk factors of this patient, the medical history and the current symptoms, The patient was referred at first to an orthopedist for clarification of his leg discomfort instead of screening this patient for lower extremity arterial disease. And we see this from time to time, that patients are sent first to other medical specialties instead of looking to the peripheral arteries of these patients and of checking the perfusion of these patients. And it underlines the need for an increased awareness of lower extremity arterial disease, of course, in both in asymptomatic as well as in symptomatic patients.
But 62, excuse me, but 62 years is not that old.
It's not that old. Nevertheless, he was smoking for quite a long time before. He had arterial hypertension, and he had an acute MI with 62 years, or at that time it was 60. Yeah.
So polyvascular disease.
Polyvascular disease, exactly. We know that, of course, the presence of typical clinical symptoms that are compatible with lower extremity arterial disease, such as claudication, of course, increase the likelihood for the diagnosis of lead, as well as typical clinical signs such as skin changes, for example, differences in temperature or loss of hair, or also the presence of broods over the iliac arteries, the femoral arteries, or the popliteal arteries increase the pretest probability for the diagnosis of lead. And most importantly, maybe what should be done in the first step of clinical examination when screening patients for low extremity arterial disease is, of course, to have a look on the patient's feet and to do a pulse palpation. And we know from large screening trials such as this, it is a Danish screening trial, the Viborg Vascular screening trial, which was performed in more than 18,600 patients. This trial demonstrated the use of pulse palpation as initial step during screening for lower extremity arterial disease, and it reported a sensitivity and specificity of around 70%. Importantly, the negative predictive value was quite high. It was about 95% in this trial. In contrast, the positive predictive value was much lower. What does this mean in clinical practice? It means that if you can feel all distal pulses, the pulses of the dorsalis pedis arteries and of the posterior tibial arteries, you can be quite sure that no severe lower extremity arterial disease is present in this patient. However, if you do not feel the pulses, if you cannot feel the pulses, then you have not established the diagnosis yet and you need further tests. And this is what was the case in our patient, in our 62-year-old patient, smoker, history of MI. We were not able to feel distal pulses in this patient, and this brought us to the question, which I now hand over to the audience, which diagnostic instrument is recommended as first-line non-invasive test after clinical examination for screening and diagnosis of low extremity arterial disease? Is it a duplex scan? Is it a treadmill test? Is it an ankle brachial index test? Or is it an MR angiography?
Okay.
What I can tell you from the clinical practice is that we are confronted with all these test results. Patients are sent to our outpatients clinic with all of these results.
Oh, that's interesting. It's 2/3 is ankle brachial index, ABI, and 1/3 is duplex. The duplex scan. What do you think about that?
The correct answer would be the ankle brachial index, and I will show you. It's a very easy test that can be performed after short training. It can be performed by a nurse, by a trained nurse. It's very easy and very fast to do. As you can see here, this is the current recommendation of the guidelines. The measurement of the ankle brachial index is indicated as a first-line non-invasive test for screening and diagnosis of lower extremity arterial disease. Of course, for reliable determination of the ankle brachial index, we need some prerequisites. As you can see here, the measurement should be done in a supine position of the patient, and the patient should rest for about 5 to 10 minutes in a room with a constant room temperature. The cuffs should be placed around the patient's upper arms, as you can see here on the images, and just above the ankles. And the ankle brachial index is then determined as ratio between the highest systolic ankle blood pressure and the highest brachial systolic blood pressure. Going a little bit more into detail now regarding the measurement of the ankle systolic blood pressure by Doppler, it's important to use cuffs with an adequate cuff size, which means they have to be a size of at least 40% of the respective limb circumference. Some of these patients have wounds, we know this. In these cases, we need impermeable dressings to cover these wounds. And of course, sometimes we do measurements in patients who have undergone vascular surgery before. And if this is a patient with a peripheral distal bypass, we have to be careful because these cuffs may damage distal bypasses under cuff compression. This can cause bypass thrombosis. We should use Doppler probes with a frequency of 5 to 10 megahertz, and for measurement they have to be placed above the dorsalis pedis artery or anterior and posterior tibial artery.
Just one question. Does it matter whether you measure first at the ankle or at the foot or at the arm?
No, I think if you're relying to the resting period, then it does not measure. But I will show you it can have an impact, that there might be some differences from one measurement to the other, as I will show you in a few seconds. For the brachial artery measurement, it's important to use the highest systolic brachial blood pressure of both arms for both legs, which means that if you have a higher blood pressure on the left arm, you have to use this for the right leg as well for the calculation of the ABI. The systolic blood pressure difference can be larger if it is above 15 millimeters of mercury. You have to be aware of that this might indicate the presence of subclavian artery stenosis. And as I've just tried to mention before, if there is a time interval, there can also be some white coat effect which might affect the measurement. There are some patients, it's a small group of patients, which have falsely low systolic blood pressures on both arms. And this is sometimes found in younger patients, sometimes female patients with vasculitis, for example, Takayasu's arthritis, giant cell vasculitis, which can affect both subclavian arteries, leading to bilateral subclavian arterial stenosis, which of course is a rare event and much rarer than lower extremity arterial disease, which is frequent. Regarding the measurement of the ankle brachial index for screening for lower extremity arterial disease, it's important to report the ABI separately for each leg. And an ABI value of less than 0.9 is the threshold for the diagnosis of lower extremity arterial disease. We know that we can use the ABI for screening for lead, but besides this, it's very useful also as a tool for cardiovascular risk stratification. And for that, we should use the lowest ABI value of the right and the left leg. And it is well known from large epidemiological studies, as you can see here, that the lower the ankle brachial index gets, the higher the overall cardiovascular risk increases in patients, which applies for both sexes, for male patients as well as for women. And if you're going to high ABI values, as you can see here, the ABI here is greater than 1.4. This curve is increasing again. It's a J-shaped curve. And the explanation for this is that vessel calcification may cause very high ABI values, as I will show you later, and then is also a surrogate for advanced atherosclerosis. Again, we know from this meta-analysis, which included 16 large population-based cohort studies, that the ankle brachial index also contributes to risk stratification in addition to the Framingham risk score, also for men as well as for women. Let me further address another issue when measuring the ankle brachial index, which is measuring the exercise ankle brachial index. We have some patients which are often younger patients, more active patients, but which also have lower extremity arterial disease. And in these patients, we sometimes have the case that we measure an ABI above 0.9 or borderline values of the ABI, despite patients are reporting typical symptoms for lower extremity arterial disease. And in this case, it really makes sense to do an exercise ABI test, because this increases the diagnostic sensitivity for lower extremity arterial disease by about 20%. What does it mean? It means that we put the patient either on a treadmill or, much more easier, do heel raises with the patient and then measure the ABI again after exercise provocation and compare it to the baseline value. And if we see a decrease of the ankle pressure that is greater than 30 millimeters of mercury, or a decrease of the ABI of more than 20%, this is indicative for the presence of lower extremity arterial disease.
But Oliver, that's also the reason why you said earlier that you need a resting phase when you do a resting ABI, otherwise...
Exactly, yeah. And I've told you before, I'm working in a large hospital in Vienna. We have very long distances, so when the patient come to our vascular outpatients clinic, they have to walk for a long distance. Therefore, the resting period is very important before we do a baseline measurement for the ABI.
Otherwise it gets too low. Oliver, I have another question for the diagnostic, because 1/3 of the viewers said duplex ultrasound instead of ABI. You want to comment on that? Is it wrong to do a duplex ultrasound?
No, I would not say it's wrong. It's different, and the difference, let me point out 2 points. The one point is that you get better information regarding arterial peripheral compensation when you're doing the ABI. Sometimes, especially in patients with borderline values, it might be helpful to do an ABI first. And the second point, maybe more important, is that for duplex scan, you need really a lot of training. It takes a lot of time doing a duplex scan of the whole leg. It may take, let's say, 15 minutes, 20 minutes, 30 minutes if you're doing it very carefully. ABI measurement takes 5 minutes resting period, and then maybe 5 to 10 minutes of the measurement, and can be done by a trained nurse. So I think this is the big advantage of doing
But
the
it's
ABI.
not exclusive. It's a different tool. And duplex, of course, has the advantage. It's non-invasive and gives you a lot
it's
of
non-invasive,
information.
and as I will show later, may give an additive information to the ABI.
By the way, that was one question to the audience.
Let's maybe come back to our case. It was the 62-year-old male patient with claudication in his right leg. We did, of course, the ABI in this patient, as you can see here on this slide. This is one of our technicians. She's here measuring with this Doppler probe the systolic blood pressure over the posterior tibial artery, here over the dorsalis pedis or anterior tibial artery, and here the brachial arterial systolic blood pressure. And this is a little bit smaller. I hope you can read it, but I can tell you here on the right leg, the ABI was very low with 0.35. On the left leg, the patient was not symptomatic, but we still found low extremity arterial disease with an ABI below 0.9 on the left side as well.
It's not very surprising that he's
It's
not symptomatic, because he will stop because of his right leg.
Yes.
And so he will have no pain on the left one.
As I've just told you before, we did then a duplex scan in this patient, and here you can see the video clip. This is the right femoral bifurcation of this male patient with claudication. You clearly can see a lot of calcification, wall irregularities, and you can also see that the common femoral artery is free, the deep femoral artery is also free, and here was an occlusion of the right superficial femoral artery. This artery was occluded over a distance of about 20 centimeters, and distal of this occlusion we found this post-occlusive flow profile in the spectral duplex scan in this patient. And this is what Rupert just mentioned before. It is not exclusive, of course. Duplex ultrasound is indicated as a first-line imaging method to confirm lead lesions in these patients.
Just one more question. You showed the oscillometric, the cuffs, and I think of the oscillometric measurement. Do you think the oscillometric measurement is recommended as well as a screening tool, or what do you think?
Actually, it's possible to use it. We are a specialized clinic at our department. We use both methods. For screening, the ABI should be preferred because you can selectively measure one artery by the other, and the oscillometric measurement does a measurement over the whole leg circumference, which always gives you higher values than you will find when you're measuring a selective artery with the probe. Let's maybe proceed with another clinical case. It's a case of a 78-year-old female patient now. She came to our outpatients clinic with an ulceration here on her right big toe. The patient did not report pain. The reason for this is that she was suffering from diabetes mellitus over years. The onset of symptoms was approximately 4 weeks ago. And of course, now we were feeling the pulses. We were not able to feel distal pulses in this patient. And then we performed an ABI measurement. And as you can see here, we measured an ankle brachial index of 1.4 in this right foot or leg and of 1.3 in the right leg. And at first sight, this might again appear a little bit surprising because this patient has a severe medical history with a history of coronary arterial disease, cerebrovascular arterial disease, and diabetes mellitus for several years. Besides diabetes, the risk factor profile included arterial hypertension. And the question is, how can this be explained that we're measuring an ABI above 0.9, which was the threshold for peripheral arterial disease, despite this risk factor profile and this typical vascular lesion, which is acral at this foot? And the explanation for this is, I've briefly mentioned it before, that these patients with diabetes, or also often patients with chronic kidney disease, have severe medial calcinosis, and this causes an increase in arterial stiffness and a decreased arterial compressibility during cuff compression with the ABI measurement, which then results in falsely high ankle pressures. So now we had this patient, this old lady with diabetes, this ulceration on her right big toe, and an ABI of 1.4. And now I'm asking the audience which diagnostic test should now be added to the ankle brachial index in case of falsely high ankle pressures due to medial calcinosis. Would you do a catheter angiography? Would you do a toe pressure measurement? Would you apply a near-infrared spectroscopy, or would you send this patient to a CT angiography? I think the answer to this question is not 100%. I think it's debatable.
Let's see what we get.
And I'm very interested what the audience will answer.
Yes, we have the result. It's the top is 59% the CT angiography, and the toe pressure measurement is second, and catheter angiography is third. So yeah,
that's interesting. I will show you what I would do. What I would not really do as a first step is the CT angiography, and the reason for this is that it is an invasive examination. You need contrast media. These patients with diabetes for a long time, especially if they have such severe advanced lower extremity and peripheral arterial disease, often have problems with their kidney function. And in addition, you do not get any information on the peripheral compensation. And the last point why I would not do the CT angiography is that if these vessels are that calcified, you only see a lot of calcium, but you cannot see, especially in the calf arteries, whether they are open or not. It can end up in a test result which does not give you any additional information. So what I would do is either number 1 or 2. And when adhering to guidelines, what we do usually do at our outpatients clinic is that we do another non-invasive test, and this is the toe pressure measurements.
Yeah. But on the other hand, you could argue, I mean, this lady had skin necrosis, necrosis of the toe, and so you want to do revascularization.
Exactly, and this is the reason why I would choose between 1 and 2, because what is clear is that this patient will need an invasive treatment, or at least an invasive examination with a catheter to have the possibility to reopen up the distal arteries. But I would not put another contrast media examination in between, because this means contrast media twice.
Can you say just one word to a near-infrared spectroscopy?
Yeah, it's an examination that is not very often done in patients with peripheral arterial disease. It is a method that is used mostly in cardiovascular surgery or at intensive care units. We, for example, use it in patients going cardiac surgery that receive ECMOs for peripheral perfusion monitoring. These probes can be applied to the patient's skin to get a continuous information on the tissue oxygenation when, for example, a patient has ECMO cannulation in the groin, which may impair arterial blood flow to the foot. But it's clearly no test for an outpatient's clinic as a screening tool. What is recommended as next step is the measurement of the toe pressure. And the reason for this is that the toe arteries are, in most cases, much less calcified than the lower limb arteries, even in the calf. And this means that you get pressure values that are much more reliable. A toe pressure value of less than 30 millimeters of mercury is compatible with the presence of critical limb-threatening ischemia. In some studies, a toe brachial index is also calculated. In the literature, different cutoff values are used. Most studies use a cutoff of 0.7. Another alternative method is the measurement of the transcutaneous oxygen partial pressure, which is also a non-invasive test, applying probes to the skin that measure tissue oxygenation, and here we also have a cutoff of 30 millimeters of mercury as cutoff for critical limb-threatening ischemia, and this is what is recommended by guidelines, that if you have a value of the ABI greater than 1.4, that you should use alternative methods to clarify the presence of lower extremity arterial disease.
Just one question, who should use this? Is this clearly a lot of training needed to interpret the data or to make the measurement, or is it clearly in the hand of the angiologist, or may a cardiologist use this as well? What do you think?
I think you probably will need a little bit more of training compared to the let's say simple ABI measurement. And what I would say, what the message is, that if you have a patient with diabetes or chronic kidney disease and you're measuring an ABI that is high, this does not mean that this patient has no lead, and I would recommend to refer such a patient to a vascular clinic for further tests, and then it can be decided whether to do TBI, toe pressure, TCPO2, or whatever. However, if someone is experienced with toe pressure measurement, I think does not mean that he cannot do it.
Okay.
So I think I'm coming to the end of my presentation. What I'm trying to summarize now in the end is to give the recommendations again, who should have an ABI measurement or who should be screened for low extremity arterial disease. And these are first patients with clinical suspicion for low extremity arterial disease. These are patients in which you cannot feel distal pulses, which have typical symptoms such as claudication. I think Rupert mentioned it before, it's important to ask the patients whether they have leg symptoms, the patient with buttock pain you mentioned, or non-healing peripheral wounds. The second group are patients that are at risk for low extremity arterial disease because of the following conditions: atherosclerotic disease at other locations, coronary artery disease, or other conditions such as aortic aneurysm, which is also associated with lower extremity arterial disease, chronic kidney disease, and heart failure. And the third groups are asymptomatic patients that have a higher risk. We know what Rupert has nicely shown before, that the incidence increases with increasing age. Men and women aged above 65 should be screened below 65 and a high cardiovascular risk factor profile. And if there is a family history of lower extremity arterial disease, we also should actively screen for lead.
Just to get a question for that, it seems to me that you have to screen everybody, nearly regarding your recommendation at the end. Is it in that way, or what is the most important? Yes, what is the most important?
Yes, I would not say everybody, but I would say is screening is not only ABI measurement, but also includes taking the medical history of the patient, viewing the risk factor profile, and asking for symptoms. And then I would selectively decide which patients to screen. But you're totally right, there are a lot of risk factors for developing lower extremity arterial disease.
There are coming a couple of questions coming here. Just one very simple. What about e-cigarettes? Is e-cigarette to a risk factor for lead? What do you know about that?
Actually, I'm not aware of a large study that assessed the impact of e-cigarettes on lower limb arteries. But I would not say they do not exert any risk. So I would screen if this is a man, for example, at the age of 70 who has stopped smoking, and in most cases these are patients that are former smokers. I do not think that there are so many patients starting with e-cigarette smoking, so mostly these are patients which have a history of smoking, and this increases the risk of lead. I don't know what you think.
No, it's clearly, because I mean, we don't have this long follow-up that we have for cigarette smoking, and it's clear that it's mostly those that had smoked cigarettes and now are shifting to e-cigarettes, and they have, of course, their long-standing risk anyway. So I think they are at high risk.
I think there's one really interesting question. What is the sequence of ABI measurement in a patient? For example, if you have an ABI of 1, when is it recommended to make the next measurement? Or if you have let's 0.9, not below. What is the sequence of that? What do you think?
Yeah, well, I think it's again, to reiterate that everything above 0.9 is normal, and so that's good information for the patient. If it's below 0.9, this patient has lead, and then I think it's necessary to repeat that after. Depending on symptoms, if there are new symptoms, you would do it immediately. Otherwise, I would screen that patient or measure that patient again on a regular basis. I don't know which interval would you use in a patient who is asymptomatic with 0.8 ABI, but this is lead. This is lead.
Yeah. I would also recommend repeating the measurement. And maybe if the patient is not asymptomatic but reporting symptoms, thinking of doing an exercise test and measuring ABI after exercise once more.
In any case, I think this is a risk patient. So we have to really consider risk factor management, lifestyle, smoking, and looking at all the risk factors. And that's I think, important.
Yeah, you mentioned the exercise testing. There's one question regarding the value of it. Is there a place for pre or post exercise functional study to localize the most critical lesion?
Well, this is not so easy to answer. What we are mostly doing at our clinic is that we are thinking of femoropopliteal lesions that we are asking the patient to do heel raises as provocation maneuver. If we are thinking of lesions that are more proximal, we are asking the patients of doing knee bends. The background of this is the groups of muscles that you're provocating with the respective maneuvers, because the femoropopliteal arterial segment mainly goes into the calf muscles, which you're activating during heel raises. And the iliac arteries and above mainly are going into buttock and thigh muscles, which you are activating during knee bends.
I think that's an important message also for the symptoms. So usually the symptoms appear one level lower than the occlusion or the stenosis. So if a patient has an aortic or iliac atherosclerosis, may have buttock claudication, typically there is an affection of the superficial femoral artery, and those patients have calf intermittent claudication, calf pain, and so it's usually one level below the occlusion.
And I think it also highlights how important the medical history and the conversation with the patient is. You get a lot of information if you're asking the patient about the pain quality. Does the pain start, for example, with the first step after sitting, or is it a pain that starts after 10 meters, 50 meters, 100 meters? You get a lot of information on the probability of diagnosis or of the affected segment during the conversation.
So there's just an additional question to that. Is it possible that if people bike, that they only have pain while biking? So on the upper leg, do you have any experience in that? There are more e-bikes now on the streets and more elderly people doing that?
Patients with lead usually do not have problems when they bike. There are some professional bikers that have special lesions in the iliac arteries, but usually they don't have problems, lead patients don't have problems biking. On the other hand, if you do exercise for a lower limb arterial disease, biking does not help. Biking is good, but it does not help. It's walking training, it's walking exercise that really improves the symptoms and the collateralization.
Okay. There's another question here. There is a study in literature which shows that measuring separately blood pressure in the left and right side gives a more accurate result. I think they mean left and right side at the brachial and left and right side at the, of course, at the ankle as well. But what about the brachial, I think? Is there...
Yes, different studies have been done on using the right or the left side for the right and the left legs, and even studies have been done for using average values of both sides. The current recommendation is to use the higher brachial blood pressure for both legs for determination of lead.
Okay.
And the reason for this is that you increase the sensitivity, because the brachial blood pressure is below the ratio, and therefore you will get with higher likelihood the lower value of ABI.
Yeah. And should we screen all diabetic patients? Or even pre-diabetic patients? What if they're...
I think this is clear. We should screen diabetic patients. And what I think is also important, that ABI is very important screening tool, but we should also look on the feet of diabetic patients. As I've shown in the clinical case, many diabetic patients have chronic wounds, and they are not aware of this because they often also have retinopathy, cannot see it, they do not feel it, and this really is a big issue.
Now I get in not so many questions, but thanks to these nice presentations from Turkey, from Ukraine, and so on, just to mention it. So you do very well job. Last question, what I think with time, exercise training for management of claudication intermittence. Maybe just a look into the treatment. I avoid all the questions regarding medical treatment, but what do you think of that? Is it important?
I think it's very important. It's, out of my point of view, it should be, and it is recommended to be the first step in patients with intermittent claudication, to send them for exercise, to exercise training for at least 3 to 6 months. The best way would be supervised exercise training 3 times a week, 45 minutes at least each time. And thereby you really can get surprising results.
Okay. So thank you very much. I think exercise is very important. I love that in that regard. And we are approaching the end of the webinar, and I would like to close this session by summarizing the key messages for you, your daily practice. Lower extremity artery disease, lead, is often underdiagnosed. I think that is clear. Is very common and has an increasing prevalence beyond the age of 65. Diagnosis is simple by clinical evaluation and by the measurement of ABI. Is often combined with coronary and carotid artery disease, and more often in patients with diabetes and high risk factor burden. And lower extremity artery disease patients are at high risk for MACE and major adverse limb events, need effective treatment to prevent MACE and MALE. Thank you to Professor Bauersachs and to Professor Schlager for this presentation. This program is supported by Bayer in the form of an educational grant. The scientific program has not been influenced in any way by the sponsor. You will be able to watch this webinar on demand on the ESC website. Thank you and good evening.